So this was someone who was bleeding and hypotensive, came down actually from the GI lab. They said there's just too much blood in the colon, and got access, and my C2 went right into the SMA. I had no pre-imaging here. So this is the first run that we had.
Hey.
And, good old SMA. And so I try to inject and carry on, to a venous phase. I think that we're all taught that, carry it out to a venous phase. And then you have to look. So this is this run here.
Hey, Sabeen, real quick, are you always using an injector?
Yeah.
Okay.
Yeah, I am. I'm always using injector. And, I'm injecting pretty high volumes. I honestly, at this point, when patients are bleeding pretty badly, in neuro, we say neurons over nephrons. I mean,
I like that. What rate are you usually doing?
This one's usually a 4 for 20 or 4 for 25.
Okay.
And it's, if I'm doing like an IO case, then I'm probably total volume at 12 or something for this. Maybe this I'm 20 to 30 cc's volume total. And you really want to just overload that system. What do you guys use?
6 for 24.
Oh, nice. 6. So are you putting your what are you putting your base catheter further into the vessel?
Good question. It depends. My standard that I usually pull is a sauce. If there's any aneurysmal dilatation, I'm having trouble with it. My next is usually a Mickelson or a Simmons 1, even though that's really not going to help me for the big aortas. I still love it. But what I do is if I get a good run, like a good fill with a hand injection, then I just go with that 6 for 24 with the catheter in, just a little ways. If I'm not getting much, either because the patient's big or he's moving around a lot, I will switch out for Cobra, and I'll actually park it like pretty far down there, like over a wire.
Mm-hmm.
Like I try to get, it depends on where I'm looking. Like if I'm really looking at like ilium or, right hemicolon, then I'll park it in there pretty far. If I need to see those proximal branches, I'll park it, a few centimeters in, but I at least I go over the hump if I can't get a good hand injection.
I like that, and especially with your injection 6. I mean, you're going to reflux. You're probably, even if you dive that Cobra, into the mid SMA, you're going to reflux back, and fill all those branches. So, that's the one thing I started loving about, in training, I definitely would use reverse curve catheters for all visceral. That's kind of what they taught, pretty dogmatically. But I changed over a Cobra because you can really just, in most anatomy, you can put that Cobra down to the SMA over a glide wire like very easily, but just carefully. Same with the celiac, you can put that Cobra in the GDA if you wanted to. It goes. It's just nice. And I mean, the most important thing is use your injections. I mean, a rate of 6 cc is great. I mean, you gotta push that blood. I mean, you can't do like puny injections here.
Hey, just real quick, since this is pulled up, you talk about finding your celiac and your SMA. Are there bony landmarks you can go by? Because we're not doing aortograms, right? So you're just kind of pulling it down. You start up high and you kind of pull it down. Are there bony landmarks you can go by to help you kind of find those origins?
I guess, what do you use, Mike? I guess I just start around the top of L1 or bottom of the T12, right?
I use CTA first, and if I don't have a CTA, I start kind of at T12. And just pull down until I get something.
Yeah, you just pull down, I just puff, and boom, get into something. And again, if it's the SMA one, even if I wanted the celiac first, if I'm an SMA, I'm just gonna take it and go. It's nice when you hit the celiac first because then it's just pulling down,
Right.